Hi all, welcome to Lung Ultrasound, Nuts and Bolts and COVID-19. I'm Rachel Liu. I'm faculty of the Department of Emergency Medicine at Yale School of Medicine and the Director of Point of Care Ultrasound Education for Yale School of Medicine. So today, I just wanted to give you some basics about how to perform lung ultrasound, especially with COVID-19 being such a prevalent disease at the moment, and we're all battling trying to deliver patient care in a very quick time frame using this technology. So I'll show you some lung findings which may suggest infection, including COVID, and describe the role of lung ultrasound in clinical care for COVID patients. Now, I have an emergency medicine background. Many of you may not. And so how this gets delivered in your clinical setting, you might have to think about, but I'll share some experiences that we've had. So of course, why are we doing this? This snapshot is from yesterday when we in the world surpassed 1 million COVID-19 positive patients. Different areas of the US are being hit differently, with a lot in New York, obviously suffering through many cases. And we've learned from the Italians and the Chinese how ultrasound was helpful in their practices. So I'm quickly going to go through, especially for those of you who already have some ultrasound experience, how we perform lung ultrasound. And some of you may be OBs who have curvilinear transducers already, who can quickly learn this. Some of you may do a lot of MSK ultrasound, and you can do it with a linear probe. And some of us may be cardiologists who are very well versed with the phased array probe. And so for lung imaging, we can do it with any of these three traditional probes. Often, to really interrogate the pleural line, we like to see the most resolution as possible, so some people default to linear, but curvilinear and phased array are quite acceptable as well. A lot of us start with the sagittal approach, and this is so that in one intercostal space, we can be sure to identify a rib above and a rib below and make sure we're in that intercostal space. And then if we find an area that needs further looking, then we might turn the probe into a transverse view to only be in that intercostal space. Now, just a word about zones. If you were to read a lot of literature about lung ultrasound, there have been as many as 28 or so lung zones described, and as few as 4 lung zones described. And a lot of us in the simplistic view try to stick with whatever is the simplest. And so most of us actually do a 6-zone approach, where the first zone is the upper anterior chest wall. Second is right below that in the mid to lower anterior chest wall. And then we divide the lateral and posterior chest walls into upper and lower, which creates our 3rd through 6th zones. To be honest, I even think that is a little difficult, and so I just break it down into 3 areas: anterior, lateral, and posterior. And just by interrogating thoroughly in these 3 areas, it gives me a good platform to work with. There was recently a JUM publication, I think it came out last week, that suggested a 14-zone approach, and that's what some of the Italians are using. But in my point of view, 3 areas, anterior, lateral, posterior, will get you as much of your chest wall as you need to. So what you also might see is a really cool technique called the Lawnmower technique, and much thanks to Dr. Joe Bernardi, who provided this slide. And if you want to see a really good POCUS video, he also has made one on YouTube. So just YouTube Dr. Minardi. And what he'll do is he starts from kind of the costal margin area where the diaphragm will be, and he lawnmowers his way up the whole anterior field, and then does the same with the lateral field and the same with the posterior field. I personally start from above and do the same but opposite. And so there's not one right or wrong way to do it. It's just your preference. So let me show you how I approach the scan. Hi all, I'm going to show you how to scan the lung really quickly. Meet Doug, he's one of my first year med students who's kindly agreed to be our model today. And I'm going to show you how to do this with a curvilinear probe. A lot of people will be using also the linear probe, or for those of us who also do echo, we might even do it with the phased array probe. So with the curvilinear probe, I'm going to start in his anterior zone and with a sagittal view. And so that means my probe marker is facing towards his head, or in this case, towards the ceiling. So some people do this a little bit differently. So some people start down here so they can get the diaphragm and then zigzag their way up. Because I'm usually doing some form of echo or something like that anyway, I'm going to start up here and literally zigzag between the intercostal spaces like this until I kind of start reaching the costal margin. If I find an area that I want to interrogate more, then I might consider turning the probe transversely so that I can actually look into that specific intercostal space more. So then I'll have Doug show me his right side. And for this one, you might have to ask the patient to put their arm behind their head so that you can get into the lateral chest wall. And again, I'm going to start in the sagittal section and lawnmower my way through until I kind of hit the diaphragm and the pleural space. If I want to interrogate further, then again, I can change it to a transverse view. And lastly, we'll go to our posterior chest wall. And so Doug, you can turn toward your back is towards camera. I'm going to ask Doug to give himself a little hug. And by doing that, his scapula will kind of move out laterally to the sides. And I'm going to start up here and zigzag my way down here. And once I start getting around the scapula, I'm going to start going out to the side like this so I can get this kind of posterior lateral side point. And again, at any point in this, if I want to interrogate in intercostal space more, I will turn transversely. Then you do the exact same thing on the other side. Okay, so now we went through how to scan. Let's look at what the lung will actually look like. And just realize that because the lung is full of air, in a normal patient, you won't see the lung parenchyma because it's full of air, and air will scatter the sound waves. The actual parenchyma might be visible if something is pathologic, however. And so a lot of our ultrasound findings are based on artifacts created by water, fluid, air, debris, coinciding with organ tissue that don't appear normally in a patient. If you are interested in looking at any of this further, I would suggest reading some of the seminal articles on lung ultrasound by Dr. Daniel Lichtenstein. So the four main things that are evaluated in point of care lung ultrasound are for pneumothorax and pleural effusion. And since they're not exactly part of COVID right now, I'm not going to concentrate on those as much, but I'll also tell you a little bit of the findings that we see in consolidations or pneumonias and alveolar interstitial syndrome. Alveolar interstitial syndrome is kind of a fancy way of saying that there is water in the pulmonary interstitium surrounding the alveoli that shouldn't be there, whether it's just serous fluid or whether it's infectious fluid or some other categorization. And I also want to put a caveat out there that even if you see these lung findings, that does not necessarily confirm a diagnosis of COVID. But if you have an unwell patient in front of you and these are COVID times, it can suggest COVID if your clinical suspicion for the same is really high. I also wanted to point out that alveolar interstitial syndrome has many other differentials apart from COVID, such as pulmonary edema for CHF, pulmonary contusion in the setting of trauma, ARDS, flash pulmonary edema from non-cardiac causes, and etc. So when I put the probe on a patient, this is what I might see. And this is with a linear probe, and so our resolution is going to be nice and pretty. And since I'm in a sagittal view, I identify a rib space above. The rib space above is closer to the probe marker line, and then the bottom rib is that rib right there. That's away from the probe marker side. And in this intercostal space, I'm seeing the pleural line, which is the kind of mashing of your visceral and parietal pleura sliding against one another as the patient breathes. In a normal profile, I'm also seeing these horizontal A lines, which are equidistant from the pleural line. I'm not really going to go into the physics of how this happens, but this is a kind of a normal appearance, and you will see the same appearance if you're using a phased array or a curvilinear probe in the lung setting. So if you're using a curvilinear probe and you're kind of by the costal margin, this is the appearance that you might see. And for those of you who do abdominal imaging, you'll recognize this view as having a liver, a kidney, and the diaphragm. And in abdominal imaging, we're mostly focused in this part. But in thoracic cavity imaging, we're focused on the space above the diaphragm. And here, in this normal appearance, you kind of see nothing there, or you see some mirroring of the homogeneous architecture, the mirror of the liver over the diaphragm. And this will become important later on. So we showed you what normal looks like. What does abnormal look like? So over here on the right of the picture, this is that same normal appearance with the ribs, the pleural line, and your A lines. And compare it with the image on the left. So now I still have my rib. The pleural line is there, but see how the pleural line is kind of irregular appearing? It's a little bit lumpy and bumpy. And then we have these vertical lines that extend the full field of view, and those are called B lines. I'm also not really going to go into the physics of why this happens, but it occurs because now there is water or fluid or some sort of debris surrounding the alveoli that sound waves can ping off. So these are B lines. B lines will erase A lines, and B lines will extend to the full field of view. And it's probably a good idea to have at least 8 to 10 centimeters of view if possible. These are what B lines look like in some of the other transducers. And so this is a phased array right now. And so I have a rib up here. My pleural line is here. It also looks kind of irregular. And I have these B lines shooting down. And now this is with a curvilinear probe. My rib shadows and rib spaces are here. And this is a pleural line that's kind of thick and has convalescent B lines. And so that's B lines that are coalescing together, and you can't really actually see individual ones. Both of these were taken in COVID positive patients. So those are B lines. And I mentioned before pleural irregularity and pleural thickening. So this is one of our earlier COVID patients. And on the patient's left, with a phased array probe, I'm seeing a rib cortex with shadow, rib cortex with shadow. So here is the pleural line right there. And I don't really see any B lines coming off. It's a little grainy because we're using the echo setting and not the lung setting. and I'm not also paying attention to harmonics or focal zones here. But if you compare it with the image on the right, now I can see that the right side has substantially thickening of the pleural line compared to the left, with B lines that are extending full field. And so pleural thickening is also an aspect that can be seen in pneumonitis. With both B lines and pleural thickening, and actually any of the other pathologies that we go through, it's patchy. And so what you see in one area may not be what you see in another area. And so if I look in just this view, I have one intercostal space on this side and an other intercostal space on this side separated by the rib. And here, I don't really see too much pleural thickening, but on this side, the pleural line looks fairly irregular. So even in one field of view, if you're able to interrogate several intercostal spaces at one time, you can get some comparisons. Next, we come to subpleural consolidations. And again, if I'm looking at the pleural line, here's my rib and rib cortex. My pleural line is here. See, if I try to follow this line, it's not really so linear. It kind of goes like this, and then it dives under, and then continues. And this area right here looks a little circular, adherent to the pleural line. And so this is an example of a smaller subpleural consolidation surrounded by a couple B lines. So there it is there. And then in this next image, these get really tricky because it can be really hard to see unless you kind of focus very specifically on the pleural line. Here's my pleural line, and if I look right here, there's a crevice with a probably circular subpleural consolidation. And subpleural consolidations don't always have to be circular. They can be irregularly or triangular shaped. They can be ovular. You're just looking for kind of a divot where the pleural line is. When they become larger, they're easier to see. And so here is a linear probe actually spanning several intercostal spaces, and the whole pleural surface is entirely disrupted. It's not a linear line, it's really lumpy and bumpy. And the consolidation is large enough that this whole area is probably consolidated, and so the whole thing shifts back and forth as the patient breathes. And the same with this image on the right. It's not just the pleural line that's moving, it's the whole block and the whole field of view, which lets you know that there is a larger consolidative process going on. If you're using a phased array or a curvilinear probe, and one area that we really want to focus on is that posterior lateral kind of aspect, so that we can get the diaphragm, which is here, in view. If we interrogate the space that is above the diaphragm, you know, in that normal image that I showed you before, we only saw some mirroring of the liver, and we did not see any of the thoracic spine. So here we see the thoracic spine. In a normal patient, the lung is full of air, and so therefore you'll never see the thoracic spine because the sound wave scatters before it can reach the thoracic spine. But if you have a pleural effusion or a consolidation or some pathologic process, now the sound wave has a medium to travel through and actually hit your thoracic spine. So this is called spine sign. And up here is a consolidation, or it could be atelectasis or something. But you see these kind of air bronchograms, and these are static ones. But a dynamic air bronchogram indicates true pneumonia. But these are consolidative processes. And here's another one where I see my diaphragm again. This black stuff is a pleural effusion with lung that's consolidated floating in it. And again, I see my thoracic spine, so there's a spine sign here. Just a note that in COVID-19, pleural effusions have been described but are atypical. However, we also know that there can be co-infections in COVID-19 with the virus and other respiratory illnesses like pneumonia, so they can coexist. So those are just some examples of pulmonary findings. How ultrasound, plays a role in our patient care at this time has been really to try to limit exposure of personnel, for instance, radiology techs for CTs and X-rays. We want to try to avoid contamination of radiology suites, and so performing bedside ultrasound or portable ultrasound has been really kind of emphasized so that we can try to preserve PPE, preserve exposure of personnel, because oftentimes the evaluator has to be in PPE in any way to go evaluate these patients. So they might as well perform the ultrasound as well. So FYI, last week, AIUM did publish quick guides on COVID-19 protections. And so I encourage you to go to the AIUM site to look at the COVID-19 resources. And this gives good guides on what personnel should do to protect themselves and how to protect the machines and use the machines in a safe way to avoid them becoming fomites. So a lot of us have talked about how to use ultrasound in our clinical care. And the reality is, unfortunately, we just don't have time or resources to perform on everybody who we suspect with COVID-19. So I personally have done it on discharged patients to try to get a baseline or to reassure well patients who are infected. When they start feeling worse, I do a lung ultrasound to show them that they may have findings and that we can see these findings, but if they're not hypoxic, then they're probably going to be safe to stay at home anyway, but it gives us a baseline in case they return in a deteriorated fashion. For the patients who are sick enough to become admitted to the hospital, then establishing a baseline respiratory function as well as cardiac function can be really helpful for the inpatient team who might have to deal with these patients when they're deteriorating. And so if they are able to do some monitoring in the inpatient floors or the ICUs and compare it to our ones that we have on admission at time 0, they can see if the condition is progressing quickly or not progressing as quickly, and that can be a reassurance as well. So I just wanted to leave you with a case description of one of my personal cases. And this is a not so elderly, but kind of middle-aged gentleman who presented to us in pretty significant respiratory distress. The O2 sat of this patient was around 70%, and on a non-rebreather increased to maybe 83%. And so this patient was intubated and admitted to the MICU. On evaluation of the left lung, you can see that there's findings in almost all these areas that we explored. There's some scant looking B lines on this side, but pretty flagrant looking B lines and actually coalesced B lines on this field. And this field was the left anterior zone, actually. And then if we go to the right, kind of the same. We have this patchy appearance where there are some scant B lines in this field, but pretty flagrant B lines in this field. And if I look carefully at the pleural line in this particular area, then I think I see a circular subpleural consolidation that's disrupting the pleural line right there. So patchy B lines, patchy subpleural consolidations are all findings with COVID. Now, not a topic in this video, but most of us are combining our lung with echo. And so we try to get a baseline cardiac function for these patients because unfortunately COVID has direct and indirect effects on the heart, especially when we start putting them in high PEEP settings during intubation. And to get volume status, we look at the IVC, and we know one strategy is to try to avoid overloading these patients with fluid, and we try to keep them kind of dry so that we don't run into an overload picture. And so titrating fluids or starting pressors early is something that we rely on in terms of our management. So this is just some echo views that we get along with our lung views. But that was kind of a crash course in lung ultrasound. And just to summarize, I encourage everyone to look at the FAIUM quick guides to scan safely. And in summary, the following pathologies that may suggest viral illness, like COVID, would be pleural thickening, or irregular appearance of the pleural line, patchy B lines bilaterally, subpleural consolidations, which are also in patchy areas bilaterally, larger consolidations, and although an atypical feature, a pleural effusion may suggest some form of pneumonia or infective process as well. Of course, all of these have different differentials in settings or clinical presentations that are not suggestive of infection, so just keep that in mind. And there's some references there in the bottom. But I thank you for taking the time to listen to this webinar. And if you have any questions, please feel free to contact me.